Hello and welcome to the latest edition of our Wednesday webinar series. My name is Jason Merrill with Barnes-Jewish Hospital. With me is Dr. Mitch Faddis. Today we're talking about a topic that is an incredibly common heart arrhythmia called atrial fibrillation. And it's a topic that we get a lot of visits to our website about. It's a question a lot of people get diagnosed with, so they go to find out more about it. So I think this is a topic of a lot of interest. So our guest today is Dr. Mitch Faddis. He is section head of electrophysiology at the Washington University and Barnes-Jewish Heart and Vascular Center. Dr. Faddis, thanks for being here with us today.
My pleasure. It's a pleasure. I take care of atrial fibrillation about half of the time as a doctor, so it's a major issue that I face and my patients face, so I'm happy to be here today.
No problem. Well, let's just start from the beginning. What is atrial fibrillation?
Well, most people realize the heart's a mechanical pump, but it's electrically active. And there are a variety of ways that the heart can malfunction electrically. Atrial fibrillation is the most common way. Atrial fibrillation is a condition that involves the top part of the heart, the atria, the upper chambers, and it's essentially an electrical storm. The condition causes the heart to race in general, but not in all cases. And more importantly, it produces a condition where blood can form small blood clots in the nooks and crannies that occur in the upper chambers of the heart because of a lack of mechanical function when the upper chambers are in atrial fibrillation.
Okay, so now we've established what atrial fibrillation is. We'll be asking a lot of questions here between myself and Dr. Faddis, but we're taking your questions as well. So you can, during this live webinar, email us at barnesjewish@bjc.org, tweet us at barnesjewish, or our Facebook page, facebook.com/barnesjewishhospital. I've got all of that here, and I have a couple of questions that have already been emailed that we'll get into later. So how common is atrial fibrillation? Again, I was saying we get a lot of people who visit our website about it. How common is it?
Well, among the electrical problems that can happen in the heart, atrial fibrillation is by far and away the most common. Numerically, in the United States, about 3 million people suffer. And the trajectory of the demographics are that it increases as the population ages, as obesity becomes more common, as we get better at taking care of cardiovascular disease, people live longer. A side effect of many of the conditions in the heart is atrial fibrillation. So it's on a steady rise, and it's becoming a major drain on healthcare resources and a challenge for patients and physicians to take care of.
What are symptoms?
The most common symptom is the sensation of an irregular, rapid pulse. Additionally, patients tend to be short of breath. They can have lightheadedness or chest pain in severe cases. Most people feel some limitation in their ability to do activities. They feel fatigue, they feel shortness of breath with mild levels of activity that they weren't accustomed to. There are a substantial number of patients with atrial fibrillation that are asymptomatic. That's a nice thing if it happens. It tends to be in patients where their natural heart rate in response to the atrial fibrillation is in the normal range. So that's a major determinant of the intensity of the sensations patients experience, is how fast the heart goes in response to the atrial fibrillation.
I got an email from Judy, who had asked earlier that her husband has trouble even walking up steps from shortness of breath. That is an atrial fibrillation symptom, correct?
It is. It's a symptom that can go along with a lot of conditions that affect the heart. But in the presence of a heart that's structurally normal, atrial fibrillation, that's the most common complaint that patients have.
Okay. Now, if someone has these symptoms, I mean, some people might say, geez, I'm just out of shape and I can't get up the steps. How do they differentiate to the point where maybe they have something more going on?
Well, I think that's a difficulty. The bottom line is patients should seek medical care when they've detected some major change in how they feel and how they perform with activity. Some patients are just tremendously fatigued. They're unable to effectively work through a full day of work. and they need to be evaluated. There are a lot of conditions that appear similar in terms of symptoms, and atrial fibrillation is a very common one of those possibilities.
Yeah. So if they have the symptoms, they go to their, what should they do? Should they go to a cardiologist first? They go to their primary care provider?
Well, a primary care provider would be the most common first place to go. Many patients have a cardiologist for other problems they're facing, and certainly going there as a first step would be appropriate in those patients. The EKG, electrical recording of the heart, is the gold standard diagnostic test that shows us what the electrical behavior of the heart is and allows us to diagnose a condition. And any doctor's office, certainly in patients who feel terrible enough to go to the emergency room, the diagnosis is made in that setting.
Are there any risk factors involved?
Many risk factors. Most patients with atrial fibrillation have some chronic health condition that's impacting the heart, and essentially the deterioration that those conditions causes to the heart leads to atrial fibrillation. The minority of patients that I see who have atrial fibrillation as essentially a standalone electrical condition seem to have a different disease, even though the manifestation, the electrical behavior, is the same. So in the lion's share of patients with atrial fibrillation, they have one or several of the risk factors that are most common, hypertension being numerically the most common, but obesity. The risk for atrial fibrillation is linearly related to the BMI, even down into the normal body weight range. So there's no weight that you're absolutely protected from AFib, and the larger people get, the more likely atrial fibrillations to occur. Age is a risk factor. It's a disease of an aging population. By age 80, 10% of patients have atrial fibrillation. Obstructive sleep apnea, it's a common sequela of obesity, very potent cause of atrial fibrillation. Treatment with a CPAP machine, it's a way to inflate the airways while asleep to protect patients against the toxic effects of sleep apnea, is protective and may modify the propensity to develop atrial fibrillation, probably helps in the efficacy of any treatment for atrial fibrillation. Diabetes is a separate risk factor as well. Cardiac disease is a potent risk factor, but in the demographics of atrial fibrillation patients, it actually is a small piece of the total. So for example, if you have a bad valve in your heart, it's a very potent risk factor, particularly the mitral valve. I think that's a good overview of that.
So what are some of the effects atrial fibrillation can have on the heart?
Well, I think the most important is the lack of mechanical function in the upper chambers that falls from the atrial fibrillation. The electrical activity in the upper chambers is trying to go at between 300 and 400 beats a minute. That's beyond what the mechanical action of that upper chamber can keep up with. And as a result, there are lots of areas in the upper chambers that aren't effectively rinsed of blood with every heartbeat. During the normal heartbeat, that happens once a second, so there's an effective translocation or movement of blood in and out of those spaces. But in atrial fibrillation, the heart is essentially quivering, and none of those nooks and crannies are clear to blood. Blood clots can form, and then those blood clots can flow out of the heart into the brain, causing a stroke. Unfortunately, atrial fibrillation accounts for probably a third of all strokes that happen. A secondary issue with atrial fibrillation is a loss of mechanical efficiency. The heart's essentially a two-stage pump, where the top stage preloads the bottom stage, which does the lion's share of the pumping action. So when you lose that pre-stage, essentially the turbocharged stage, the total output of the heart is diminished by something like 10 to 25%. So if you think of it as an 8-cylinder car, you go into atrial fibrillation, you've lost essentially 2 of those cylinders. You can still drive around, but the car runs rough because there's misfiring. That's a nice analogy for atrial fibrillation.
Okay. We have a question from Terry Relford Weisenbach on Facebook that says, I had AFib once. Am I prone to get it again?
Yes. There are acute illnesses that can cause atrial fibrillation. For example, pneumonia, pulmonary embolus, which is a blood clot to the lungs, a thyroid disorder where the thyroid is hyperfunctioning, producing too much thyroid hormone. All those conditions can cause atrial fibrillation because of an acute stress. So I think that the long-term risk is diminished if those conditions are treated. But by and large, if you've had AFib once, you're likely to have it again in the future.
Now, when you were going through the risk factors a minute ago, or the effects of atrial fibrillation, you mentioned stroke. How serious is the risk of stroke from AFib?
It varies. There is a variety of systems that we use as physicians to try to estimate that risk going forward in time. And the most well-known is a system called the CHADS risk score. And each letter in that acronym stands for the major risks. So C stands for congestive heart failure, the H stands for hypertension, the A stands for age greater than 75, the D stands for diabetes, and then the S stands for prior history of a stroke, which is a very potent risk factor for an additional stroke in the future. Those risk factors taken together account for the majority of the risk of stroke. If you don't have any of them, your risk of stroke is less than 1% per year. If you have one, then the risk is somewhere around 4 to 5% per year. And the more risk you have, the more factors beyond that, the risk escalates.
Okay. Let's get into the treatment options. So there are several different options at hand, but the first step you take generally is medications, correct? What are some of the medications, and how do you try to treat the AFib that way?
There are two issues by today's standard of care, and they need to be considered separately. The first issue is, what is the stroke risk and how can that be mitigated? As I said, that the CHADS risk score is very helpful, and the issue here is that the way to prevent stroke is to use blood thinner, but the risk of taking a blood thinner is not insignificant. So you run a risk of life-threatening bleeding by taking a potent blood thinner, and that risk needs to be below the benefit for it to make sense. So say that another way, it's possible in a low-risk patient to give them a much higher risk of dying from life-threatening bleeding by using these potent blood thinners. So that doesn't make sense. But in patients with significant risk factors, that risk-benefit ratio is favorable, and they need to be on a potent blood thinner. In other patients, an aspirin a day, if they can take it, is enough to protect them against that risk. So that's step one, is what is the stroke risk, and are those patients candidates for a potent blood thinner, like warfarin or a new drug called Pradaxa? And then step two is to ask, is there an impact on quality of life? We've went through the symptoms, but there is, as I mentioned, a substantial number of patients who don't feel atrial fibrillation. In those patients, there's really no justification for aggressive treatment for the atrial fibrillation. The only caveat to that, I would say, is that the pulse rate needs to be in a physiologic range at rest. And that's a broad definition, but in my practice, I want those patients to have an average pulse substantially less than 100 beats a minute over a 24-hour period. I think that if their resting pulse is above that, there's some risk that the heart will weaken over time, essentially like asking the heart to run a marathon day after day. The heart's a muscle and it will fatigue over time. So I do look for that, and even in patients who don't really complain of specific atrial fibrillation symptoms. Now we come to the patients who really feel lousy with the atrial fibrillation and have the classic symptoms. And there we try an escalating approach. The first step generally is to try to reduce the pulse rate. Sometimes that's enough for patients to feel much more comfortable. Some patients have intermittent AFib, and that's a challenging group. Their AFib starts and stops spontaneously, unpredictably. Sometimes their pulse is nice and normal, and other times it's racing. That's a difficult problem to treat because the side effect of many of the medications is to slow the pulse. So when the patients are in normal rhythm, they don't feel well because the medications are slowing their pulse too much. There is a class of medications that have a primary electrical effect. They're called antiarrhythmics. The goal of these medications is to block the AFib. I wish I could say they work like antibiotics where you take the medication and it flushes out the problem. But the reality is they basically distort the electrical behavior of the heart in a way that may prevent atrial fibrillation. They're not terribly effective, unfortunately. They tend to be toxic. Our worst fear is that they would promote essentially a cardiac arrest, and we look at that very seriously by starting medications in a controlled environment like the hospital. The only exception to that is a new medication called Multac, which can be started as an outpatient because the risk of those life-threatening electrical problems seems to be very, very low. So that's the next step, is to look at this class of drugs. Many patients fall right through that class. They can't identify one that seems to work or be tolerable, and then we're in the class of treatments that are invasive. And among those treatments, we have catheter ablation, where we try to electrically isolate or segregate the most important regions of the heart that drive the atrial fibrillation. We have Cox Maze surgery, which was developed here at Washington University. That's the gold standard for curing atrial fibrillation, devised in the 1980s. Long-standing cures are possible with that. It's an open heart procedure. Cure rates approach 90%. The goal is to create an elaborate network of scars that act like barriers or barricades. The catheter treatment attempts to duplicate some pieces of that procedure, but is in no way an attempt to duplicate the Maze procedure in the heart. And then we've also developed a hybrid procedure where we look at the best parts of the catheter treatment and the best parts of the surgery and try to translate that into a minimally invasive procedure. The surgical procedure is done through small ports or small holes in the chest wall as opposed to opening the chest and putting the heart in bypass surgery. Some of the ablation can be done with catheter. A lot of the testing can be done with catheter. And the result is a procedure we hope is superior to the catheter treatment, which often requires a second course of ablation, and much less invasive than the full-blown Cox Maze procedure. And that's an overview of all the treatments. I haven't mentioned an old-fashioned treatment, which is ablation of the AV node and installation of a pacemaker. A lot of patients have the perception that the pacemaker has a preventative value and their doctor has recommended a pacemaker, but that's really a misconception. The reality is that a slow pulse is also a consequence of atrial fibrillation, either the condition itself or treatment with the drugs. Pacemakers are necessary to sustain a more comfortable pulse, but it does no preventative effect. If we ablate the electrical connection between the top and the bottom of the heart, that's called the AV node. That's a very simple thing to do. It's permanent, but it renders the patient completely dependent on the pacemaker system. The atrial fibrillation still exists, still participates in causing mechanical malfunction of the upper chamber, but the heart rate is under the control of the pacemaker at that point.
Okay. And to go into a bit of detail on these, ablation is not a surgical procedure. I think that's important to note because many people may think that these are surgical. So with ablation, what typically should a patient expect? It's just a visit to the cath lab, essentially, correct?
It's a prolonged visit to the cath lab. It's done through IVs that are placed in both legs. We use catheters in the heart. Catheters are thin tubes that have electrodes. One of those catheters is especially designed to apply electrical current that creates an injury. And it's essentially like a wood burning kit. We're burning a pattern on the inside of the heart, and we hope that pattern then becomes a scar tissue that's electrically inactive. And the effect of the ablation is to create a barricade or a fence around the hot spots of the atrial fibrillation. An alternative is to create roadblocks and short circuits that participate in the atrial fibrillation. The whole procedure takes on the order of 4 to 5 hours. It's done under general anesthesia. So it has some aspects that seem like surgery, but the bottom line is there's no incisions, we're not opening the chest. And the next day the patients feel almost normal. They're generally tired from a prolonged procedure, but they feel fairly normal.
There's a local company in St. Louis called Stereotaxis. Their technology was developed here at Barnes-Jewish and Washington University that you use in ablation. It's magnetic guided catheters. What exactly is that, and how is that advanced ablation?
Well, that's an exciting technology that I helped develop here since the late 90s. And the company, Stereotaxis, has been committed to expanding that development to produce a tool that will be revolutionary for curing AFib. And that's a hope. It hasn't been proven as yet. But the idea is that when I use a catheter to ablate on the inside of the heart, I'm essentially trying to write my name with a 3-foot-long pencil, holding the top end of the pencil. Well, that's inherently not a very precise thing to do. You can learn how to do it, and yes, my name can be legible, but it's just not the same as grabbing the tip and writing your name. Well, that's what the Stereotaxis system does. It translates that control to the very tip of the catheter, and then you also have the added precision that a computer provides. So I think that the potential for a very precise, essentially surgical incision like ablation can be done with this system. And whether or not large pieces of the ablation can be taken over by a computer program is a possibility. It's completely experimental at this time, but it's very exciting. What is clear is that the system has a very light touch on the inside of the heart. To control the tip with a manually held catheter, I have to apply a fair bit of pressure on the inside of the heart. And I think inherently that is a source of complications. We worry about perforating the heart or injuring some aspect of the heart. Those complications are rare, but they do occur. And I think the Stereotaxis system has some potential for being a safer way to go about treating atrial fibrillation. So it's currently been approved by the FDA. I'm using the technique at Barnes, and we're very interested in measuring how effective it is. I think that the future developments will include this more sophisticated incorporation of computer control to allow us to be more precise inside the heart.
On the other hand, with surgery, you mentioned the Cox Maze procedure that was invented here in 1987 by James Cox. That is an open surgical procedure. Compare that to ablation. With ablation, how long are you in the hospital? With Cox Maze, the open surgical procedure that also burns scar tissue onto the heart, how long are you in the hospital with a procedure like that?
Well, that's a good question, and the two are very dissimilar in that regard. So the catheter ablation is essentially an outpatient, although patients stay overnight, and they go home the next day generally, and they resume normal activity in a week. The Cox Maze procedure involves a much more substantial surgical procedure where the heart's opened. Parts of the heart are amputated. The areas that tend to form blood clots are actually removed from the heart and oversewn. Both the right upper chamber and the left upper chamber are targeted by the surgery. Patients are in the intensive care unit at least one day, and generally in the hospital for 3, 4, or 5 days. The recovery is weeks. So it's a much more invasive option. If we contrast the cure rates with persistent AFib, that's the AFib that's there every second of the day, a single treatment, but with the Cox Maze procedure cures about 90%. And that seems to be a long-standing cure. With catheter treatment, a single treatment cures only about 50%. And the 50% where it comes back, we tend to go through the same procedure, and then the cure rate goes up a bit higher, closer to 80%. It does look like if patients appear to be cured by catheter, that there is a recurrence rate that's late, So I think that the jury's still out how long-standing the effects are of catheter ablation. We do have now almost 20 years of data for the Cox Maze procedure.
So how is quality of life typically improved after these procedures?
Well, it varies substantially. Some patients, I would say the majority of patients who get a cure either by the Cox Maze or the catheter ablation, or now with the hybrid procedure, they feel like it's changed their life. They're taking less medication. They feel better. Their activity tolerance is restored. They feel very happy with the results. Other patients have chronic health conditions, and the effect is more mild. They still have the conditions that led to the atrial fibrillation. Those things don't go away, and they tend to be progressive. If they're struggling with obesity, high blood pressure, diabetes, sleep apnea, well, all of those things need to be treated. And I think that comprehensive treatment is mandatory in these patients. You can't leave any stone unturned if you really want to have a long-standing effect. So I think those are considerations as well as in terms of the quality of life.
We still have some time to take your questions. You can email us, barnesjewish@bjc.org, facebook.com/barnesjewishhospital, or you can tweet us your question at barnesjewish. I have an email here that from John Carter, and this is the subject is anticoagulation and atrial fibrillation. So this is a long one, and this is a rather technical question that is over my head. I am but a PR guy. However, I'll ask. Using low molecular weight heparin and warfarin for AFib in the elderly requires renal dosing and INR monitoring. Are there any low molecular weight heparin available for which the dose does not have to be renally adjusted? Any way to get warfarin dosing correct without having repeated blood tests? And how do you determine the dose to correspond to a specific INR goal?
Okay, that's a complicated question.
Yeah, I gathered that. Yes.
So there are a variety of essentially temporary blood thinners that can be used. The low molecular weight heparin, I think there are two on the market that are available, are often used, particularly after an ablation. It's not a long-term treatment option in patients. Rare exceptions to that. Extremely expensive medications. They uniformly have to be adjusted for kidney function because they're cleared by kidney function. So there's no way out if you're forced to use those. So if a physician is using those medications, they're taking that into consideration. And many physicians won't use them in patients who don't have normal kidney function. Among the blood thinners that are more potent that are available, we have the most information about warfarin. There is a genetic sensitivity. I should say that another way. There is a genetically determined sensitivity to the warfarin that dictates in large part what dose is effective. So there is no way to predict, short of a genetic test, which is more or less an experimental option at this point, what dose is effective. So for example, I have some patients where 1 milligram of warfarin a day produces the desired effect, which is measured by the INR test. And that desired effect is to achieve a test result of 2 to 3. That's 2 to 3 times normal. You can think the blood is thin by that extent. Where on the other hand, I have patients that require up to 30 milligrams a day to achieve the same result. So a 30-fold difference in sensitivity to the drug, and that's determined in large part by a genetic sensitivity. The other factor with the warfarin is diet. Unfortunately, the antidote to warfarin is vitamin K. Vitamin K is in a variety of foods, fresh vegetables in particular, green vegetables. It's not healthy to avoid all of those things, but it does produce effects on the INR level, causes fluctuations. A new agent that was released a little over a year ago called Pradaxa is not sensitive to the diet. It also has a more uniform effect in the population, so one size fits all essentially. It's a very exciting drug because it doesn't require blood testing. It has this lack of dietary sensitivity, lack of effects that are genetically determined. The trouble is that it's quite expensive, and that's where the rub has come. There's a new drug that will be released sometime in the next year, we hope, that has a similar effect to the Pradaxa. They haven't been compared head-to-head, but they both seem to be somewhat superior to warfarin and is similar in that it doesn't require the monitoring. So we hope that as competition and prices decline, we'll be able to use these other agents that are easier and more convenient for patients, probably safer as well.
Okay. I have a question on Facebook from Ahmed Saeed that simply says, AF in pregnancy. What are issues involving atrial fibrillation in pregnancy?
Well, that's a very challenging clinical situation. Coumadin, warfarin, is absolutely contraindicated in pregnancy. So the first step is those patients cannot get warfarin. Blood thinner, anticoagulants, blood thinners in general are problematic in pregnancy. The low molecular weight heparin can be used. It depends on the risks. The patient's risks have to be addressed and whether or not it's necessary to use an anticoagulant, but it's still a very risky situation. The other issue in pregnancy is that many of the drugs we'd like to use have effects in the fetus, and we want to avoid those if at all possible. Beta blockers, for example, are a common class of medication used to slow the pulse. They can result in intrauterine growth retardation, so try to steer clear of those. Calcium channel blockers tend to inhibit contraction of the uterus. It's a very difficult situation. Fortunately, young women aren't prone to get atrial fibrillation, so it's an extremely unusual and rare circumstance. I don't think in the last decade I've seen a patient at Barnes with pregnancy and atrial fibrillation.
I have a couple of emailed questions from Kathy. Do hormonal cycles have an effect on AFib? In other words, can it either go away or appear at menopause?
Well, that's an area where we certainly know a lot of anecdotes. Many patients feel a sudden surge in their arrhythmias around menopause or around pregnancy. The other arrhythmias that are common in young people tend to be the ones that we see in pregnancy, SVT, for example. There hasn't been any definitive analysis of those effects, so I can't say beyond the fact that yes, some people it seems to be a prominent connection.
Okay. Other question. If I think I have AFib, I've had a rapid heart rate and palpitations, should I go to my primary care doctor or should I go right to a cardiologist? And we kind of touched on that before, that primary care is generally who you see first. However, what's your reaction to that?
I think that's good. I think many patients are restricted by their health insurance to go through their primary care as the gatekeeper to the other specialists. And many primary care physicians have dealt with these issues. Palpitations are a common complaint patients have. Monitoring, essentially electrical recording that's taken with the patient, is often ordered by a primary care specialist. That's extremely helpful to produce the diagnostic information about what the heart's doing when the sensation occurs.
Okay. So overall, what's the message you want to get out to people about atrial fibrillation?
Well, it's an important condition. It has some very serious health implications. If you think you have it, I think you need to be evaluated by your physician as soon as possible. Many conditions of the heart can cause the sensations that are common in atrial fibrillation. I think they're all important. So whether or not you have atrial fibrillation, if you feel a racing pulse that's inappropriate for your level of activity, if you feel shortness of breath with activities that didn't used to produce shortness of breath, those are all warning signs that something is happening. And you may have a heart condition that needs to be considered to be treated aggressively. So I think that to prevent strokes, we have to recognize these conditions before the strokes have happened. And because a third of strokes are happening because of the atrial fibrillation, it's a major player in that regard.
Okay. Dr. Faddis, thank you for your time today.
My pleasure.
Thank you. And thank you for everyone who's asked questions today. We will be back here next Wednesday for another Wednesday webinar. Gerald Andriel, Chief of Urology at Washington University and Barnes Jewish, will be here to talk about prostate cancer. The PSA test is going to be a big topic of discussion because he's actually recommending that patients avoid mass screening for PSA and have a more targeted approach. So we'll talk about that next week. This, if you just tuned in late and you missed the beginning, we will have this online on our website, barnesjewish.org/webinar. It'll be posted tomorrow, so you can watch the whole thing at your leisure. We'll also have it on our YouTube page, Facebook, Twitter, all of those. So thanks for joining us, and we'll see you next Wednesday.